Hi, my name is Abdul. Today I'll be showing you how to use the Life Pack. What we do with the Life Pack 15 is that we turn it on first. After you turn it on, what I'm going to do is, before I even do an operation check, it goes automatically into AAD mode. So what I do is I press Energy Select, change it to manual, and for the sake of the video I'll put the energy on about 50 joules. What I do next is I attach this to the test load. After that I'm going to press options and use a test. And while it's doing the testing, I'm going to show you how to use a suction. With regards to suction, we have to see if there's any damage to the suction. There's no damage. It's been turned on the suction. Battery capacity, it's full. What we want to do is we want to occlude the tube till it gets about 350 millimeters of mercury. If it doesn't get up to over 350 or to 350, we must check that everything is being closed properly. There's no occlusions and everything like that. Also have the water on the side, just in case. So the Life Pack then prints a sheet of paper that tells you the user test has passed, and then what you do is you rip that off and then you just put it somewhere. After next I'm going to show you how to charge the Life Pack 15. So you press charge. Next it's going to advise you to do a shock. You press red button, shock. If I want to disarm the Life Pack and not advise a shock for a patient, what I do is I press charge, then I press the speed down, and that disarms it. Next, what I'm going to show you is I'm going to connect the this wire to the simulator over here, and it's going to show us hopefully a normal rhythm. So we then turn on the simulator and press the on button. It turns on and gives us an automatic, a normal sinus rhythm. When we want to look at the leads, we press lead, and if you want this 2 lead, there's your 2 lead. If you want 1, if you want 2, 1 leads and all that sort of stuff, shows you everything over here. If you want to adjust the volume, what you press is you press options, go down to alarm, volume, press that and puts the volume. If I want to look into the QRS volume, and if I'm transporting the patient on the ambulance or on the stretcher and I want to hear the cardiac rhythm, what I would press is the speed dial. I'll then go to the 72 over here, press that, the QRS volume comes up. I'll then select that, put the volume up to the highest volume possible. Lastly, what I'm going to show you is with regards to the leads. If you want to increase the amplitude, you just press size, and you have ranging from 0.25 right to 4.0. If I want to, that's the size. Lastly, this is the EP20. So I'll show you where to connect this one. It's over here, as you can see, CO2 over here. You just connect that, screw it on, make sure it's tightly in there. And that's all that for Life Pack 15. In this video I'm going to demonstrate how to use an OPA, MPA, a bag valve mask, oxygen and suction. Patients who are unconscious and unresponsive, who have a GCS of less than 8, tend to have a respiratory, tend to have a body that sort of collapses, their muscles relax, causing the tongue to block their throats. So for patients like this, they are unable to control things such as vomiting. So what we want to do is, for patients like this, we want to have a suction machine next to us, just in case the patient, as we go, the patient's vomiting. What we want to do is we want to place the patient in a lateral position. We want to place the patient in a lateral position to let all the vomit out. And then what we do is we turn the suction on the young cure. We then place the young cure in the back of the throat as far as you can see. And then we occlude this hole over here and suction on our way out. We want to do this no more than 10 seconds. More than 10 seconds can cause complications such as hypoxia and laryngospasm. So we then place the patient back in their spine, in the supine position. And what I want to do is I want to do manual maneuver and head back, chin lift, head tilt, chin lift, and place it between my legs to open the airway. I'm going to demonstrate how to use an OPA, an oropharyngeal airway. We use an airway when we suspect when we see the patient is unresponsive and unconscious. What tends to happen with patients like this is that their muscles relax, tongue falls to the back of their throat, causing airway occlusion. So what this OPA is doing is that it's opening the airway, maintaining and protecting it. Before we put in the OPA, we have to measure it from the tip of their mouth over here, the lips over here, right to the edge of their mandible. How we insert it, we put it like this, upside down in the mouth, make sure we don't catch the tongue. We then turn it at a 180-degree angle, just place it under their lips and hold it between their teeth over here. Complications of an OPA include things such as trismus, which is locking of the jaw. Another complication is gastric reflux, so patients who, if the OPA is a bit too, if it's not measured properly and it's too large, it can cause a gag reflex. Or if the patient is not responding properly to an OPA, what we do is we use an NPA, a nasopharyngeal airway, and we measure this from the tip of from the large nose down to the edge of the mandible over here. And before we insert the NPA, we have to lubricate it. The nose of our noses are very vascular, full of a lot of blood vessels. So last thing you want to do is cause a lot of damage and bleeding to the patient's nose. How we insert the NPA is we put it in like that slowly, and if you are experiencing any sort of resistance, you want to slowly turn. If you're still experiencing resistance, what you want to do is try the other nostril. Try the other nostril over here. Turn, turn. In this video, I'll be going through oxygen, ways to identify oxygen, and also I'll be going through the mask. So I'll be administering and giving this acute mask to the patient while connecting it to the oxygen. So ways to identify the oxygen include they come in a white cylinder. So usually it says oxygen on the side. With regards to oxygen, we also have to we have a regulator. The regulator tells us the pressure that's within the cylinder. It also tells us when the oxygen is refilling or the amount of content within the cylinder. So this regulator also has a product seal. Product seal is responsible for keeping that seal, so preventing air from escaping the oxygen cylinder. So now what I'm going to do is connect this oxygen regulator to the oxygen cylinder. Also, just extra information with regards to, we don't want to make it too tight, we make it just right. We also have labels over here that tell us, for example, at the moment, this oxygen cylinder should be full. Once it's in use, I will then remove that tag, and it should have in use, and once it's finished, it's empty. Okay, so now I'm going to turn on the oxygen. As you can see from here, it says full. Okay. So now what I'm going to do is I'm going to give this acute mask to the patient when we would give a Q mask is, for example, when a patient is feeling a bit, for example, a patient who's had a a heart attack or something like that, or asthma, we might give them because their tissues need perfusion and they've been with the oxygen for a period of time. So I just connect the tubing over here. Tell the patient that, so it's okay if I administer this oxygen for you?
Yeah.
So it's going to help you, your tissues get that nutrients and that blood it requires for you to feel fit and healthy again. So with regards to a Q mask, it delivers about 60% of oxygen. We want to set it up to about 6 to 8 liters, so I'll put in 8 liters. So is it okay if I put this on for you?
Yeah.
So then just place it behind here. Don't want to be too irritant or anything like that. Is that okay, sir? Okay. So that's how you give a acute mask and deliver oxygen to a patient. So you're feeling okay now?
Yeah, that's good.
Alright. So now I'm going to take this off, alright? Alright. So now what I'm going to do is just turn off the oxygen. So once I've turned off the valve pillar, I then take off the tubing over here, and then there's going to be still a lot of pressure there. So what I'm going to do is release that pressure. In this video, I'm going to demonstrate split management with regards to a fracture. I'm also going to cover pharmacology, so I'm going to talk about interlocks and analgesia for pain relief. So I have a patient who's come, who's presented to me. Sir, how are you feeling? What's happened?
I found out my arm.
Okay. Did you hear any noises during this incident? Due to the mechanism of injury, I'm suspecting a possible fracture because I can see swelling, deformity in this region over here. So possible ulnar and radius fracture. Sir, are you in any pain at the moment? Can you give me, on a scale of 0 to 10, 10 being the worst pain, what you would rate this? About an 8. Okay, are you allergic to any medication? Have you been scuba diving within the last 24 hours? You don't have any bowel obstruction? Okay, and obviously I'm looking at the patient, I'm assessing their breathing. Breathing seems to be normal, normal chest rise and fall, no possible suspicion of pneumothorax. Sir, I'm going to ask you to lift your arm for me. Which one? This one, the normal arm. Okay, put it down. Okay, so the patient is able to obey command. So what I'm going to do is I'm going to give the patient Entonox, which is an analgesia, which is for moderate to severe pain. So firstly, I'm going to turn on the Entonox. Okay. So what you're going to do is you're going to put your mouth in this mouthpiece over here. You're going to breathe in as much as you can, okay, and breathe out. After 6 breaths, you might feel a bit of a euphoria, might feel a bit sedated, you might feel a bit nauseous. You may also get a sense of a dry mouth, okay, so a metallic taste. So I'll get you to have the pain relief. So the patient has had his 6 breaths and the pain has gone away. Okay. So I'll turn off the Entonox. Okay. Usually when a patient injures his arm or breaks or anything like that, they tend to go to their normal, comfortable position. So as you can see, the patient's wrist is not straight to anything. That's not going to put any pressure on the area of the injury. So he's a bit relaxed at the moment. So I'm going to get this link over here, put it on his knee. Okay. So usually I'll have someone here helping me, but I'm a single unit today, so I'm going to have to do this by myself. Okay. I'm going to get the joint close to the elbow joint, the wrist joint over here. I'm going to carefully lift him. Okay. And place him in there. How's that, sir? I'll get you to relax your elbows for me. There you go. Next I'm going to get the triangular bandage. And before I do that, I'm going to test the patient's neurological and cardiovascular assessment. I'm going to do a cardiovascular and neurological assessment. Sir, can you wiggle your fingers for me? Okay. The pain relief should have kicked in by now. So I'm going to look at the patient's pulse. Yep, normal. Not irregular or anything. Capillary refill, less than 3 seconds. Less than 3 seconds. Sir, can you feel this? Yep. Seems like the patient's arms are both warm. This is warm and this is slightly warm. So this is going to be much warmer because you have an inflammatory response with that fracture. So I'm going to put this triangular bandage over here, just over here. Okay. So what I'm doing is I'm putting this close to the joints to sort of immobilize it, so that they don't put any pressure on the fracture. Then I'm going to tighten it back here. Okay. Then I'm going to put the last one over here, close to the wrist joints. Okay. You don't want to make it too tight, you just want to make it just right. So is that okay with you, sir? Okay. Lastly, before, yes, you don't need a splint. Okay. So he does not need a sling. Usually with patients, they tend to just prefer to hold it by themselves at times. Lastly, I'm going to do I'm going to do one more cardiovascular neurological assessment. Sir, can you wiggle your fingers for me one more time, please? I'm going to look at the capillary refill, both less than 3 seconds. Pulse, regular. And it's warm. Sir, can you feel this? So that's a good neurological and cardiovascular assessment. That is a bit of pharmacology and splinting. In this video I'm going to demonstrate how we can do catastrophic hemorrhage, how we can manage it, how we can manage hemorrhage as well. So a wound site that's bleeding, how we can dress it, and all those sorts of methods. So now we can see that this mannequin over here, the patient over here, is bleeding profusely in his upper thigh region. So we know the thigh is has a very high blood volume, so we don't want this patient going into hypovolemic shock. What we do is we expose the wound site, then get the tourniquet, apply the tourniquet. What we're going to do is we're going to apply the tourniquet 10 centimeters above the site of the wound. What we want to do is make the tourniquet as tight as possible. We then twist it over here. So twist until the bleeding stops over here, and then we look for the distal pulses, such as osseous pedis pulse, pedal pulse. So there's no pulses, meaning the tourniquet has done its required job. We then document the time over here. If necessary, during the process of dressing, there's still a bit of bleeding, what we do is we apply a second tourniquet proximal to the first. Now for hemorrhage control, now that we can see the wound site is just over here, what we must make sure is that the site is cleaned well, so that we don't introduce infection, and that so the patient may have further complications during their hospitalization, such as infections, exposure to microorganisms. We also can take a picture of the wound site, if possible, and show it to the staff at the ED department. So because we're going to dress this wound, and we don't want them to interfere with the clotting factor. So now what I do is I apply this dressing over here. So we use the smallest dressing possible. Put pressure, apply pressure on the wound site. Get the bandage over here. Go around the wound site in a circular motion. We want to make it as tight as possible. Okay. So to make it tight, what we do is we do the twisting method to sort of apply more compression to the site. So twist. Twist. And if there was for more bleeding to occur, what we will do, we'll stuff more dressing within the bleeding area if there was more bleeding to occur. So now I'm almost done with the dressing over here. Now, I'm going to apply that. In this video, I'm going to be demonstrating how to measure and use the C-spine collar. I'm also going to go through the Nexus criteria. So I have a patient here with me today. I'm on a single crew. So, sir, my name is Abdul. I'm a paramedic student from AUT.
Hey,
What's your name?
Sam.
Sam, are you okay? What's wrong?
I fell and hit my back.
Where are you feeling the pain in your back?
Yeah.
Okay. Do you know where you are?
Yeah, AUT.
You know what time of the day it is?
Yeah, it's about lunchtime.
So this patient scored 5 out of 5 in the verbal score, so he's orientated to time, place, and person. So do you have any pain in the back of your spine over here?
No.
So there's no C-spine tenderness or any midline tenderness. Have you had anything to drink today?
No, I have had no alcohol today.
No alcohol today, very good. So there's no intoxication or anything like that. So now I'm just going to do a neurological assessment, look at his movement, sensation, all that sort of stuff. So do you feel this on the inside or the outside of your arms?
Inside.
Yeah?
Outside.
Okay, can you lift your arms for me? Good. Squeeze my arms as hard as you can. Very good. Put it back down. Wiggle your toes for me, sir. Very good. So, Sam, I'm also going to, if I have my partner with me, we'll look into the lower portions of the limbs and do a Babinski sign and all that sort of stuff. Okay. So, Sam, you said you've got a sore back.
Yeah.
Okay. If this patient was to fail the Nexus criteria, I would apply a C-collar. C-collar is there to immobilize the patient so that they don't do any further damage to their spine. Because once the spine is damaged, it's not good. So how I measure it is, I just unclip this over here, measure it from just under his chin, to about his jugular nostrils, just right over here. So what I need to do is, okay. How's that, Sam?
That feels okay.
Feels okay? Okay, very good. So I'm just going to place this part over here under him. Make sure the patient doesn't move excessively during this process, as there's spinal damage, possible spinal damage. So just like that, just like that. I'm also stabilizing and allowing him to have a neutral alignment, so I'm stabilizing his neck during this process as well, between my legs. How's that, Sam?
Feels good.
Can you open your mouth for me? Very good. Try and do it. Very good. That's very good. That's how you apply it. In this video, I'm going to demonstrate vital signs, how to take vital signs. First of all, I'm going to take the patient's pulse rate. So we're looking for the rate, we're looking for the strength, and any other irregularities. So it takes about 10 seconds or so. Multiply it by 6, and that should give you the patient's pulse rate. Your one is 60, that's normal. We're looking for between 60 and 100. before I take the patient's blood pressure, I'm going to look at his breathing rate. So normal breathing rate is between 12 to 20 breaths per minute. So if I took, yep, his one is about 12, so that's perfect. So now I'm going to place this sphygmomanometer on the patient's brachial artery over here. Just place it like that. Don't want it to be too tight or too loose. You want to get the right and correct reading. So now I'm going to take the stethoscope. Pump it to about 160 to 170. Normal blood pressure for adults is 120 over 80. First sound I hear is going to be the systolic. And the last sound, diastolic. That's perfect. Your one is 130 over 63. That's normal. So now I'm going to auscultate or listen to the patient's chest. So I'm going to listen to the apex region over here and the base. Looking for any abnormal breathing sounds or anything like that. Volume and all that sort of stuff. Just going to auscultate, listen to your lungs, okay? Breathe in for me. Okay. Just going to breathe in. We're looking for any wheezing or stridor. Gonna auscultate the other side, which is normal breathing sounds. And that is how you take vital signs. So we've been called to AET, the patient who's unconscious. First of all, we have to check that the scene is safe, so that there is no risk to me and my partner over here. So we can see that the desk can be moved to the sides. No unpredictable factors. And look for the route of exit over here just in case anything goes wrong. So, and lastly but not least, we have both our PPE. So now I'm going to go and assist the patient over here. Hello sir, can you hear me? Hello? Patient's not responding to verbal stimuli, no pain stimuli. So I'm going to listen to breathing for at least 10 seconds. Looking for chest rise as well. 8, 9, 10. Patient's not breathing. Can you please get into the chest for me? AET to comms.
AET1, loud and clear.
R49 in progress, requiring R50.
Roger.
So I'm just going to be working around you right now. Replacing the pad on the patient. Doing very well, Sam. Very, very well.
Analyzing heart rhythm. Do not touch the patient.
Stay clear.
Shock advised. Charging.
Clear.
Stay clear of patient. Deliver shock now. Shock
I can just
delivered.
kick it back on, Sam.
Pause. Start
Got my suction
CPR.
here just in case the patient might vomit. As you can see, Sam's doing the compressions very nicely over here. 1/3 depth. He's doing it at a rate of 100 per minute, so that's about 30 to every 2 breaths. So Sam, tell me when you get to 30.
25, 26, 27, 28, 29, 30.
1, 2. Chest rise?
Yep, just rise.
Perfect. I'll get you to get better, please. So me and Sam will swap every 3 minutes, or once the AED monitor starts speaking again, we'll swap, or if you get tired. So let me know if you get tired, Sam.
Yep, 27, 28, 29, 30.
Perfect. 1, 2, chest rise.
Yep.
Doing very well, Sam.